Good afternoon, ladies and gentlemen. It gives me great pleasure in welcoming you to this afternoon's webinar, the topic of which is Polycystic Ovarian Syndrome, Role of Imaging. In the last several years, we have been witnessing a steep rise in the number of women presenting with PCOS, and we radiologists, especially those of us who do ultrasound, see these cases quite frequently. So this topic is very relevant to us. There is so much variability in the clinical radiological presentation with mismatch in findings. You have asymptomatic women showing polycystic morphology on sonography, and those with classical symptoms who may show no positive sonographic findings at all. Such instances used to pose a diagnostic dilemma. However, as proper diagnostic criteria have subsequently been established, adhering to this helps in overcoming this problem. And our speaker today will be elaborating on this. We have with us a very senior and eminent gynecologist, Dr. P. Balamba, to share her clinical perspective on PCOS. And to present the radiology of this condition, we have Dr. Divya Raju Alluri. It is my pleasure and privilege to welcome Dr. P. Balamba, our chief guest for this afternoon's webinar. Dr. Balamba honestly needs no introduction, but in keeping with procedure, I would like to formally introduce Madam. Dr. Balamba is an alumnus of Osmania Medical College, from where she did her undergraduation and MD in OBGYN. Madam was formerly professor and HOD, Department of OBGYN in Osmania Medical College. Dr. Balamba has held several prestigious posts, was additional superintendent of OGH, additional director of medical education in AP, professor emeritus of OBGYN in NTR University, and this is just to name a few. Dr. Balamba has published a large number of papers in national and international journals, and over the years, Madam has trained a large number of government and private medical college staff and students in obstetrics and gynecology. Currently, Madam is practicing as consultant in Shalini Hospital, Barkatpur. We are indeed fortunate to have such a senior and eminent clinician as the chief guest for today's session to share her thoughts and experience regarding today's topic. Once again, a very warm welcome to you, ma'am.
Thank you.
Our speaker for today, Dr. Divya Raju Alluri, is a graduate of SVS Medical College, Mehboob, from where she did her MBBS and MD in radiology. Currently, she is working as consultant radiologist in BDC Himayat Nagar and has been associated with Vijaya since the last 7 years. Dr. Divya is particularly interested in fetal and women's imaging. I now invite Dr. Balamba to share her thoughts on today's topic of PCOS, your clinical input, and ma'am, what you expect from a radiologist as regards diagnosis. Dr. Balamba.
Thank you, Akila. Thank you for the kind introduction. Now, PCOS, when we were students, way back in 60s, it used to be known as T-Leventhal syndrome, and where, there used to be hirsutism, infrequent periods, and then, we used to go ahead and do a wedge resection of ovaries, and there was no imaging at that point of time. There was no ultrasound scans or anything, and only clinically we used to diagnose, and we used to have what is known as a gynecography at that point of time. I don't know how many people, radiologists, will remember this gynecography, where we used to inject air into the posterior fornix, through the posterior fornix into the peritoneal cavity, and then, the air used to surround the ovaries, and we could see that they are bulky. So that is what we used to do. And of course, even in a hysterosalpingogram, we could make out when the dye falls, it used to surround the ovaries, and we could see those follicles. So all those things, are a thing of past now. It's history. Now, of course, we go more and more into ultrasound scan. And of course, we don't use the other modes of imageology like MRI or CT scan for this. And we depend solely on ultrasound scan. But then, unfortunately, the definition of polycystic ovarian syndrome or the diagnosis of polycystic ovarian syndrome is a diagnosis of exclusion. Unfortunately, many people forget it. This is where we have to exclude hypothyroidism, hypoprolactinemia, and then the late onset of adrenal hyperplasia, Cushing syndrome, and then other any ovarian tumors which are male hormone producing tumors, or maybe an adrenal hyperplasia, and then hypothalamic hypogonadotrophic amenorrhea. There's so many things which we have to exclude, and once we exclude all these things, only we can come to a conclusion that it is a polycystic ovarian syndrome, because the main feature of polycystic ovarian syndrome is hyperandrogenemia. We have three different classifications. The first classification was that of National Institute of Health American from North America, and where they said hyperandrogenemia or oligo or anovulation and polycystic ovaries on USD, which may or may not be there. That was the original diagnosis. Then ESHRE, that is the European Society of Reproductive Medicine and Embryology, and ASRM, that is American Society of Reproductive Medicine, in 2003 they came to a consensus, and they said clinical or biochemical hyperandrogenemia, and then oligo or anovulation and polycystic ovaries, where the cyst can be 2 to 9 millimeters, more than 10 in number. And then, of course, they also stressed on the stromal echogenicity. And now, of course, we also think of the ratio between the ovarian volume and the stromal echogenicity. That is also very important, which, of course, the imageology people have to tell us. Now, why does the stromal echogenicity increase? That is because number of follicles are recruited, they are coming into the fore, but then unfortunately they are not maturing, because ultimately one dominant follicle has to mature and the rest will go into atresia. But here the recruitment is much more than what normally happens, and much more follicles will go into atresia, and all these atretic follicles are going into the stroma, and that is why the stromal thickness increases. So that number of the atretic follicles which are increasing will increase the area of the stroma. So this area, the ratio of the area of the ovary plus to the stroma, that is also very important for us. So the two of these criteria were enough. So there need not be a PCOS also. Oligo or anovulation or hyperandrogenism are sufficient to diagnose polycystic ovarian syndrome, though there are no polycystic ovaries. And then the third is the Androgen Excess Society and PCOS Society classification, which came into 2006. 2006 it came into existence. They also said existence of hyperandrogenism, clinical or biochemical, and either PCOS on USD or ovulatory dysfunction. So hyperandrogenism was the main thing in Androgen Excess Society classification. Now there are four different types when we talk of this androgen excess society classification. The first phenotype is androgen excess and ovulatory dysfunction. The second, androgen excess and polycystic ovary morphology. Third is ovulatory dysfunction and PCOS morphology, no hyperandrogenism. Fourth is androgen excess, ovulatory dysfunction and PCOS, all four. And recently there has been addition to these phenotypes which has come up to P, that is A, B, C, D to P. So various combinations and permutations. So just diagnosing polycystic ovaries by imageology is not enough to label a person as having polycystic ovarian syndrome. Unfortunately, what is happening is some of the imageologists, especially the sonologists, when they do the scan, actually the scan should be transvaginal. That is when you get a good imageology and you can count the number of follicles. Now the number of follicles are supposed to be more than 12 in number, 2 to 9 millimeters in diameter, arranged as a pearl, in the periphery. That is because the atretic stroma is pushing these follicles to the periphery. So that is like a string of pearls, that is the appearance. And that is what we want you to count. So even in infertility cases, we always want an antral follicle count. The antral follicle count has to be done only between the third and the fifth day of a cycle. That is when the follicles are being recruited. And we want you to measure the number And the most important is the volume of the ovary also. The volume of the ovary has to be more than 10 ml. Then only, all these things together, you can say it's a polycystic ovarian morphology. In a normal ovary, the follicles are strewn all over the ovary. So it is not a mother of pearl, the string of pearl appearance. All over, even in the stroma, you find the follicles. Whereas in a polycystic ovarian syndrome, the stromal density is much more. That is about the imageology. But then, 25% of women between 20 years and 25 years will have this polycystic morphology, but they are not polycystic ovarian syndrome. So I don't want the sonologists to label the girls as having PCOS. Instead of saying PCOS morphology, you can tell us so many number of follicles of such and such dimension. The stromal density is so much, the volume is so much, and then you all are very fond of writing clinical correlation, no? That also you can write clinical correlation. Another thing which I find very funny in sonology's reports is, please don't take me amiss, this report is not for medico-legal purposes. Once you do the imageology, whatever report you give, that is going to be for medico-legal purpose only. So whatever I commit on paper, as a clinician is also for medico-legal purpose only. So I don't know what is the purpose of mentioning for clinical correlation, not for medico-legal purposes. So these are all funny things, I think, which you should avoid using these terminologies. This is my personal belief. I'm not finding fault with anybody. Please forgive me if I have offended you, but this is what I want. So polycystic ovaries, I have given you all the symptomatology. And then when we come to the adolescents who are not into reproductive age group, what we have to understand is adolescence is a growth stage. In the growth stage, the growth hormone also goes up, and there is an increase in the LH, right? Like in the PCOS syndrome. So naturally, there will be hyperandrogenemia and hyperinsulinemia also because of insulin resistance. And insulin resistance here is very important because for the growth, insulin resistance is important. Because these children have to grow in height and weight, and the hypothalamo-pituitary ovarian axis has to mature here. So naturally, the picture of the ovaries will be that of polycystic ovaries. In fact, some pediatric endocrinologists suggest that you should not label any adolescent as having PCOS unless they are 3 to 5 years away from the time of menarche and they are having irregular and infrequent periods associated with hyperandrogenism, that is hirsutism, and then you find this sort of a polycystic ovarian morphology, then only we can label them as having polycystic ovarian syndrome, because the picture is that of adolescents. So you can't label them that way. The problem is when you say polycystic ovaries in an adolescent, the mother is not afraid of the metabolic syndrome and associated complications of PCOS in later life. They're only worried about whether the girl is going to have children or not. They are worried about the primary infertility. And that fear you should not induce, because it is the sonologist who is inducing this fear in them the moment they label them as PCOS. And then they come and say, will my child have children? Will she have any problem? Forgetting about all the other more important complications of PCOS. Because PCOS in adolescence, PCOS in reproductive age group, PCOS in perimenopausal age, PCOS in postmenopausal age, all have their complications. And I'm glad that we are having this webinar today, because the month of September is supposed to be PCOS awareness month. So we are having this at an appropriate time. So I think you understand my perspective. And if there are any questions about this, people can ask. I have no problem.
Okay. Thank you so much, ma'am, for this very valuable piece. And now I call upon Dr. Divya to start her presentation. Over to you, Divya.
Good afternoon, everyone, please. And I would really like to thank Vijaya Diagnostic Center for giving me this opportunity to make the presentation. So we will talk about the polycystic ovarian syndrome and the role of imaging. Polycystic ovarian syndrome is the most common endocrine abnormality in women of the reproductive age and carries with it significant health risks, including infertility, endometrial hyperplasia, diabetes, and cardiovascular disease. Ovarian imaging is crucial in the evaluation of patients with suspected polycystic ovarian syndrome. Although findings of polycystic ovaries are commonly seen at routine ultrasound and are frequently not associated with the syndrome, awareness of criteria and definitions used in the diagnosis of the syndrome is important, especially in patients who are being evaluated for ovulatory dysfunction or hyperandrogenism. The imaging report should be specific and should include ovarian volumes and antral follicular counts, in addition to other pertinent findings such as the presence of a dominant follicle or a corpus luteal cyst. The clinical consequences of the syndrome are broad and extend beyond infertility and reproductive access. It is believed that insulin resistance may be central to the etiology of the syndrome and related to many of the health consequences of the polycystic ovarian syndrome. One of the most consistent biochemical features of PCOS is the hypersecretion of androgens. When LH increases relative to FSH, that is when the LH-FSH ratio is elevated, ovaries preferentially synthesize androgen. Women with PCOS usually have an increased LH-FSH ratio. The Rotterdam criteria for the diagnosis of the syndrome. These 2003 criteria required at least two of the following three conditions to be present for the diagnosis of the polycystic ovarian syndrome, they being oligo or anovulation, clinical or biochemical signs of hyperandrogenism, and polycystic ovaries. However, the most recent consensus criteria have established the ultrasound findings of polycystic ovaries as a part of the diagnostic criteria for PCOS. Ovulatory dysfunction. Although infertility is frequently seen in PCOS, a significant proportion of the women with PCOS are ovulatory, demonstrating either normal ovulatory patterns or oligomenorrhea, that is fewer than 9 menstrual cycles per year. This has important implications for ultrasound evaluation and reporting in PCOS. Ultrasound findings. The role of imaging in PCOS is to properly identify and document the presence of polycystic ovaries. However, because PCOS is by definition a syndrome, the presence of polycystic ovaries alone is insufficient for diagnosis. The clinical significance of incidentally discovered polycystic ovaries is still unknown, and women with this finding should not be considered to have the syndrome unless and until further workup has been done. The Rotterdam definition of polycystic ovary. This definition acknowledges two criteria on the basis of which a polycystic ovary may be identified: ovarian volume and number of follicles. According to consensus definition, polycystic ovaries are present when one or both ovaries demonstrate 12 or more follicles measuring 2 to 9 millimeters in diameter, or the ovarian volume exceeds 10 cc. Only one ovary meeting either of these criteria is sufficient to establish the presence of polycystic ovaries. The volume of 10 cc was selected as a threshold volume for a polycystic ovary. A volume is calculated on the basis of a simplified formula for a prolate ellipsoid, length by width by thickness. It's a diagrammatic representation of how a volume is calculated. This is an ultrasound image depicting the ellipsoid pattern based on which the volume is calculated.
So this is a transverse ultrasound image of the right ovary, which is demonstrating the classic string of pearls appearance of a polycystic ovary. According to the Rotterdam definition, this subjective appearance should not be used in place of the ovarian volume and follicle count to identify a polycystic ovary. Polycystic ovaries in patients without PCOS. Women who are undergoing investigation for other gynecologic complaints may be found to have polycystic ovaries at ultrasound. Data suggests that 23% of the women of the reproductive age will have findings of polycystic ovaries. However, only 5 to 10% of these women will have the classic symptoms of the syndrome, such as infertility, amenorrhea, signs of hirsutism, or obesity. This is the selected images from a three-dimensional ultrasound examination of the right ovary, demonstrating the determination of the number of follicles present across the entire volume of the ovary according to the Rotterdam definition. Stromal echogenicity and volume. One of the earliest described characteristics of a polycystic ovary is an increase in stromal echogenicity. Although there may have been many efforts to correlate qualitative indexes of stromal echogenicity with PCOS, the intrinsic echogenicity of the ovarian stroma is no different in PCOS than in the normal ovary. The subjective impression of increased stromal echogenicity is primarily due to increase in the stromal volume. It has been demonstrated that the increased stromal volume correlates positively with the serum androgen levels. However, no standardized method exists for determining stromal volume. because overall ovarian volume correlates well with stromal volume in polycystic ovaries and is more easily measured in clinical practice, the determination of overall ovarian volume is a reliable surrogate for ovarian stromal assessment. Imaging and reporting consideration. With regard to imaging of polycystic ovaries, transvaginal scan is preferred because it often provides optimal visualization of the internal structure of the ovary, particularly in obese patients. Data suggests that compared with the transvaginal ultrasound, the appearance of polycystic ovaries may not be detected at transabdominal ultrasound in up to 30% of the women with the polycystic ovarian syndrome. If transabdominal ultrasound is required, as may be the case in women who have never been sexually active or who decline a transvaginal scan, care should be taken that the bladder is adequately filled but not overfilled, since an overdistended bladder can compress the ovary, potentially leading to a greater deviation from the model of an ellipsoid used to calculate the volume. In addition, it may be helpful to record cine clips throughout each ovary to assist in counting the number of follicles present throughout the entire ovary. Regularly menstruating women should undergo scanning during the early follicular phase, which is between days 3 to 5. Oligo or amenorrheic women may be scanned at random or between days 3 and 5 after progesterone induced bleeding. A history of oral contraceptive use should be elicited since OC pills cause a decrease in the ovarian size, thereby decreasing the sensitivity of ultrasound evaluation. It should be noted that the Rotterdam definition of polycystic ovaries does not formally apply to women with such a history. As mentioned earlier, women with PCOS are frequently ovulatory. The presence of a dominant follicle, defined as a follicle whose longitudinal transverse and AP diameters average more than 10 millimeters, or a corpus luteum cyst may increase the ovarian volume above the 10 cc threshold. Such a finding should prompt a repeat scanning during the next menstrual cycle. Similarly, the presence of asymmetry in ovarian volume should prompt further investigation for an underlying cause, such as an isoechoic cyst or a corpus luteum. The range of the follicular sizes as well as the size of the largest follicle in each ovary as determined based on the average of measurements taken in 3 axes should be evaluated and reported. Findings in the ultrasound assessment of polycystic ovaries that should prompt repeat scanning during the next menstrual cycle, according to Rotterdam definition, are the presence of a dominant follicle with an average diameter of greater than 10 millimeters and a presence of a corpus luteum. This is a sagittal color Doppler ultrasound image of the right ovary in a patient demonstrating the presence of a corpus luteal cyst. Pertinent reporting parameters in PCOS. Relevant history, which includes age, the last menstrual period, menstrual history such as oligo or amenorrhea. As mentioned earlier, regularly menstruating women should be scanned between days 3 and 5 of their menstrual cycle. Any history of medications such as oral contraceptives, GnRH agonists, and fertility medications. Ovarian findings. Separate reporting for each ovary should be performed. The number and the size range of the follicle should be mentioned, including the size of the largest follicle in 3 axes and the average diameter calculated. Documentation of a dominant follicle or a corpus luteum, presence of either should prompt repeat ultrasound scanning during the next cycle. Careful evaluation and reporting is important since the presence of a single ovary fitting the Rotterdam definition is sufficient to diagnose polycystic ovaries. The Rotterdam definition is explicit in stating that women with polycystic ovaries but with no evidence of ovulatory dysfunction or hyperandrogenism should not be considered to have the polycystic ovarian syndrome. Evaluation for PCOS in postmenopausal women merits special consideration. Before the Rotterdam Consensus was issued, the presence of polycystic ovaries was reported in postmenopausal women, and it is discovered that the presence of the polycystic ovaries after menopause correlates with increased concentrations of serum testosterone and triglycerides with possible association with metabolic syndrome. What is known is that polycystic ovaries in postmenopausal women tend to have a greater volume, 6.4 cc versus the normal 3.7 cc, and demonstrate more follicles, 9 versus 1.7, than normal postmenopausal ovaries. There is often difficulty in distinguishing a polycystic ovary from what has traditionally been referred to as a multicystic or a multifollicular ovary, defined as an ovary in which there are 6 or more follicles, usually ranging between 4 to 10 millimeters in diameter, with normal stromal echogenicity, and described as a common appearance of ovaries in adolescence. That being said, PCOS manifests itself around the time of menarche, and premature pubarche may be a harbinger of the syndrome. MR imaging in PCOS. The use of MR imaging for the assessment of polycystic ovaries has also been explored. According to the American College of Radiology, pelvic MR imaging is recommended in cases in which ultrasound is inconclusive or non-diagnostic. The use of MR imaging is generally not warranted in the evaluation of polycystic ovaries due to its increased cost and the typically adequate visualization of the ovaries at the transvaginal ultrasound. However, MR imaging may be helpful in cases in which transvaginal ultrasound cannot be performed and transabdominal ultrasound does not offer adequate visualization, such as in the cases of extreme obesity. Although polycystic and normal ovaries appear to be distinguishable at MR imaging, the literature on MR imaging in PCOS is scant and no consensus has been reached as to an MR imaging definition of a polycystic ovary. Until more is known about the performance of MR imaging versus ultrasound, it may be practical to report the follicle counts and ovarian volume if MR imaging is performed for the assessment of polycystic ovaries. These are the coronal and the axial T2 weighted images in a young woman that demonstrate polycystic ovaries with characteristic appearance consisting of abundant hypointense central stroma with small peripherally arranged T2 hyperintense follicles. Although CT is not used in the evaluation of patients with possible PCOS, particularly since the internal ovarian structures are far better depicted at ultrasound or MR, polycystic ovaries may sometimes be seen in patients when they undergo CT for other reasons. The first image is an axial non-contrast CT demonstrating the bilateral polycystic ovaries on either side of the uterus. And the second image is a grayscale ultrasound image in the same patient with the polycystic morphology. It's obvious that ultrasound depicts the internal structure of the ovary better than CT. Ultrasound may have an additional role in the management of PCOS in patients undergoing infertility treatment. There is some evidence that ovarian volume, in addition to other factors such as body mass index, ovulatory cycle history, and serum androgen levels, may be helpful in predicting fertility outcomes in response to treatment with clomiphene citrate. Similarly, although not pertaining exclusively to patients with PCOS, the presence of polycystic ovaries may be a risk factor for ovarian hyperstimulation syndrome in women who are undergoing ovarian stimulation for in vitro fertilization. To conclude, ovarian imaging is crucial in the evaluation of patients with polycystic ovarian syndrome. The imaging report should be specific and should include ovarian volumes and antral follicle counts, in addition to pertinent findings such as the presence of a dominant follicle or a corpus luteum. Although findings of polycystic ovaries at routine ultrasound are common and are frequently not associated with the syndrome, awareness of the criteria and definitions used to diagnose the syndrome is important, particularly in patients who are being referred for evaluation of ovulatory dysfunction or hyperandrogenism. Thus, to participate in the workup, radiologists must have a working knowledge of the clinical and the imaging criteria for the syndrome. Thank you very much.
Thank you, Dr. Divya, for that detailed presentation. Over to you, Dr. Balamba, for your comments, please.
Yeah, like I said, the recent addition to this is the area, the ratio between the ovarian area and the stromal area. If the stromal area is more, that also is taken as a criteria for polycystic ovaries. So there is a difference between polycystic ovaries and a multicystic ovaries. So the multicystic ovaries, there are more follicles strewn all over the ovary, whereas the polycystic ovaries, the string of pearl appearance with the stromal echogenicity is very, very important. So the number of follicles, the dimension of the follicles are very important, as also the ovarian volume. So these three things must be mentioned whenever we refer somebody for a scan, and we never label them as PCOS. And so I think even the sonologist should not label them as PCOS. So what you can write is a PCOS morphology present instead of saying PCOS syndrome. So don't label them as syndrome. Simply say PCOS morphology. That will be much better, and than sending these women into depression and about their fertility problem and other things. So that should be the norm, I suppose. So anything else from anybody else? From the audience, any questions or no questions?
I have the chat box in front, but I don't see any questions, ma'am. I think you covered
it. Only we three are speaking to each other.
No, ma'am, I think you have covered everything, and between you and you've shared a lot of information which probably a lot of people wanted to hear and which they were unclear about. And I think that's the reason why we are not seeing any questions in the chat.
That I don't know. Confused. Either they have understood completely or they have not understood at all. They got confused.
No, I don't think that's the case. Yeah. So I think since there aren't any questions, we'll wrap up here.
Yeah.
So with this, I conclude today's session. Thank you so much, Dr. Balamba, for taking the time to be with us today and share all the information, your valuable opinion. A big thank you to the attendees, and I hope you found this session informative and interesting. I would also like to thank Dr. L.T. Kishore, our head of radiology, for all his guidance, support, and encouragement. And of course, to our institution, Vijaya Diagnostic Center, for having given us this opportunity. Thank you all and good day.
Thank you, Divya. Thank you for a very good presentation. And I hope you will present many more such webinars, All the
Thank
best.
you so much,
Thank
ma'am. Thank you
Yeah.
so much, ma'am.
Thank
Thank you so much, ma'am.
Thank
Thanks
you,
a lot.
Akila. Thank you. Bye-bye.
Thank you.
Bye, everybody.
Bye.